Welcome, everyone, to all of our viewers and listeners of MedEd Matters. I cannot believe we finally made it to our season finale for season one. It's been an awesome year. I'm your host, Omar Young. I am joined by two amazing guests today to close out our season. This season, we've taken you through what is super important and foundational for medical education. And I think we have an awesome discussion ahead of you today, particularly on focusing on educational timeouts and teaching in the operating room, which I think is super important for a variety of specialties. So I'm going to let my guests introduce themselves, and then we'll get started.
Good morning. I'm Meredith Newton. I'm one of the GYN oncologists here at UNC, and I'm very excited to be able to participate in the podcast today. Thanks for inviting us.
And I'm Jenny Haag. I'm one of the third year Gynonc fellows and also very excited to be here.
Thanks, Dr. Newton and Dr. Haig. Welcome to Med Matters. And just for all of our listeners, Dr. Haig just had a baby and she's joining us in the podcast. So please welcome her brand new addition to the UNC family. And other good news, Dr. Newton was just accepted to a MedEd educational scholarship program through APCO. So congratulations to Dr. Newton. I
Thank you.
love when people are doing great things in the space of medical education. So today's episode is going to be focused on teaching in the operating room and exactly how that impacts not just our learners, but also our teachers. And so I wanted to have a conversation with the two of you because you two are really good educators in the operating room and can really help those that may need a little bit more advice or just want to know exactly how to engage in this sometimes chaotic space. So, Dr. Newton, can you tell me from an attending perspective, what does the clinical learning environment in the operating room look like for you?
Yeah, I think the first thing that's important to recognize is that learning in the operating room starts outside of the operating room. First, it's discussing with your trainees, preparing them for the case, helping them to understand there's a lot of work that goes in before you enter the operating room, including picking the procedure, understanding the approach, what's the equipment going to be used for that day, and how do you get the patient ready for that surgery that day. And then when you walk into the operating room, I think the next thing that's really important to recognize as the attending is that there are a lot of different agendas at play. First and foremost, the patient is obviously the number one for doing that surgery that day, is making sure you're performing safe, quality patient care. But additionally, you have learners. You have learners at all different levels. That may be a medical student, resident, fellow, and each of them have different objectives they're trying to achieve through that experience. There's the staff. Everyone wants to run on time. Folks want to make sure there's the right people in the room at the right time. And as the attending, you may have other patient duties. You may be on call. You may have meetings you need to get to and family matters after the end of the day. And so I think being able to navigate all of those agendas is really key as the attending. And I think one of the last big things is recognizing that every case has different learning opportunities. It depends on if you're doing a minimally invasive procedure versus an open procedure. Those things look different. It may be a minor versus a major, or an emergent case versus an elective case. And helping people to recognize that not all learning is by doing, and being able to help people understand there's learning opportunities in many different forms in the operating room.
Thanks, Dr. Newton. So it sounds like that there's lots of competing agendas in the operating room, whether that is patient focused, learner focused, attending focused, financially focused, what have you. And so it's really, really different than when you're in, let's say, the clinic, or if you are in a, didactic or somewhere else that is more controlled. There are lots of variables that really go into play into shaping how a learning environment happens. And so
Exactly.
I'm curious, like, Dr. Haig, you are coming from this perspective as a trainee, and early congratulations on your graduation. Um, Tell me what it's like for you having been a resident, but also in this weird stage of being a fellow where like you've done a residency, but you're now, for whatever reason, trying to do more training. Tell me about what your experience has been like.
Yeah. I think, a fellow is a really unique role because you're trying, like you said, to balance still being a trainee and still being a learner, but also kind of your own um, teaching skills. And so I think something that fellows think about is, balancing getting certain skills or opportunities or practicing certain procedures and decision making that's necessary for their own, clinical development, with identifying, skills or procedures that might be more appropriate for teaching residents or students. And I think one of the things that is helpful in thinking about that is, what trainees express as their goals for certain procedures. I think lots of residents I've heard, want to open the retroperitoneum and identify the ureter in a robotic case, but maybe that's not in an endometrial cancer staging, that's not the best opportunity for that case because normally it's the fellow who's, kind of starting off and identifying the sentinel nodes. So that's generally a role for a fellow. But in simple hysterectomies, that might be kind of an opportunity for them. And so really trying to identify what the trainees' goals are and finding cases that are appropriate for that. And then I think one of the other things that I have been trying to work on this year is kind of mastering communication. I think when you know what you want to do in the procedure, but communicating how to do that to someone else, you have to find kind of the right words, which can be very tricky sometimes.
Yeah, I appreciate that. For our listeners who may not know this world, Dr. Haig, can you tell us exactly what is a GYN oncologist and what is a fellow?
A gynecologist is a subspecialty within OBGYN who manages patients who have gynecologic cancers. And a fellow role within that world is somebody who has already done a 4-year OBGYN residency and then finishes a 3 to 4 year fellowship to specialize more, learn kind of some of the more of the complex surgeries and care for patients with gynecologic cancer.
So by the end of it, you are going to be a master surgeon and a master educator. And
So
so, and so I guess it's great that I invited you here so we can talk about exactly how we function in the operating room. Dr. Newton, I'm curious to know from your past experience as a teacher in the operating room, tell me, what has worked well for you and what hasn't worked well for you in the past?
Yeah. I think the first thing that Dr. Haig already mentioned that is takes practice and is, I think, very key to education in the operating room is language. Particularly when you are operating in a minimally invasive manner. I do a lot of robotic surgery, and your hands are not physically in the field, and you can't, stop the procedure with your physically, or really take over things from a trainee is clear language. And often that is through using anatomic directions, or even, as I've learned from some other educators in the operating room, is just using more simple language. Screen up, screen down, screen right, screen left. Because sometimes when you are trying to be engaged as a learner, understanding what cephalad and caudad gets a little bit confusing.
Yes.
Yeah, yeah, it takes a little bit of even left and right can sometimes get a little confusing, but um, I think being able to be a little bit more clear so that people understand exactly what you're saying and they're not just trying to navigate the procedure and your instructions. Um, I think some other things that have been helpful in the operating room are helping people to understand the why behind what they're doing, giving them insights into what to look for, not just the motions of the procedure. I had a mentor when I was training here at UNC, Dr. Anna Marie Connolly, who used to always say, the eye doesn't see what the mind doesn't recognize. And I think that's really, as a trainee, I didn't always understand that. As faculty, I really feel like I've come to understand what that means is that it takes repetition and helping people to really see, let their mind let their eyes see the planes, let their eyes see what they're trying to achieve, and then the mind will be able to really recognize what is the proper technique, what is the right tissue handling, what is the right plane to get into, as opposed to just going through the motions and instructing on the steps of the procedure.
So it sounds like patience is something that needs to be exercised in the operating room with the learner. But you bring up a good um, point about language. I want to like jump off on that a little bit. When we talk about language, how do we establish, essentially, how do we teach that language to our learners? Like, a resident or even a medical student doesn't come into training, knowing, what a coker clamp is or where to place a stitch. How do you communicate that to your learner?
Well, I think first, kind of going off of your point about instruments and different things, I think it starts from day one when an intern's doing a C-section, helping people to learn how to instruct those around them on what the next step is. It's always call for your instrument. What suture do you actually want? Don't just ask for a stitch. And trying to think at one step ahead, always in a case of what's next. And I think part of it is modeling. It is trying to use the language that is going to be more instructive if helpful, and helping people to see that that's a more clear way to approach something than language that may just be up, down, over there, and taking a moment to pause and trying to work through that.
And recognizing that, you were in the position, a few years ago that you didn't know what you were doing, and someone actually took the time to teach you this. So it behooves you to do that for someone else.
Mhm.
So Dr. Haag, what personal past experiences with respect to teaching the operating room have you had that have been positive or negative?
I think just to piggyback off of the last kind of point about communication, which I really appreciate what Dr. Newton does in the ORS. And I don't know if this is a conscious thing or something that she just does, but she always says pause when she wants you to when she wants to make a point or kind of tell you something specific about the procedure. I think as a trainee, that's really important because it cues your brain to think that, I need to pay more attention in this moment because she's trying to direct me to do something that she wants me to do. And so I've noticed that kind of as I've been in the operating room more with her is that that is something that I think is very effective. Um, I also think, in positive experiences that I've had in the OR, it has revolved around kind of graduated autonomy. And so, things that a third year fellow might be able to do, like leading a resident through a hysterectomy or a more complicated, procedure is not something that a first year fellow is necessarily going to be able to do. But those are kind of always positive experiences when you feel like you have a good grasp of the procedure, have a good grasp of what you need to do to teach, the trainee who's operating with you, and kind of get through the procedure. I think the other thing that is nice is that, when you feel like your approach is valued, even if it's not the approach that, we end up taking in the operating room, when I think this kind of piggybacks a little bit to understanding the why of some types of techniques that we use, to even if it's not the way that the attending wants to do the procedure, to acknowledge that, that is a way that you can do it, or, to feel that you feel like a valued member of the team and not just kind of dismissed. Those have all been very positive experiences I've had in the operating room. I think negative experiences kind of revolve around some of the things that we've already talked about, multiple competing interests in the operating room, kind of feeling rushed or feeling like you don't have the time that you need or want to complete the procedure or the step of the procedure, or being in an environment where you don't necessarily feel comfortable asking questions or clarifying. I think that's something that most of our attendings do a really good job at setting a good tone in the operating room, one that you feel like you can be comfortable. but have definitely had some experiences where that's not the case.
And I wonder, you know, let's do a thought experiment for a second. If I'm an attending, I'm operating regularly, and you tell me that I need to engage in teaching, and I tell you I don't have time for that. No one's taught me that, or that's not what I signed up for. What do you say, Dr. Haag, to that from a fellow perspective? And what do you say, Dr. Newton, as an attending?
I definitely acknowledge that that's maybe not something that people feel comfortable with, as I think it's, kind of sometimes crazy that we as clinicians are kind of expected to just pick up on how to be an educator without, without necessarily having formal teaching. You know, people who are very high up in the academic world oftentimes have many years of experience and kind of formalized education about how to teach. And so definitely acknowledge that that's a tough skill to just kind of pick up. But I do think that there are opportunities for even, the smallest little bit of teaching here and there that can develop into more kind of robust teaching experiences, even just kind of pointing out anatomy or pointing out the different spaces of the pelvis or, the course of the ureter. I think starting small and kind of developing as you develop kind of your teaching style, kind of continuing to um, yeah, develop that.
Dr. Newton?
Yeah, I think it can start with some small, like Dr. Haig said, some small measures. I think one of the keys, particularly when thinking about the competing interests, particularly of time, is that when you set expectations at the beginning of the procedure, when you set goals, when you at least take that step to be intentional there, you can then be able to balance those agendas, those needs, because you can either help correct individuals on what their expectations should be. You, as the surgeon, knows the case the best. You know potentially where the pitfalls are going to be, what the challenges are going to be, and maybe X, Y, or Z goal from a resident isn't appropriate. And so if you set that from the get-go, you can narrow down achievable goals that don't necessarily have to totally prolong the entire day. So I think that's one. And I think, and if people know what their goal is and they get that accomplished, they feel accomplished for the day, even if it's just one small step to the procedure. And I think the other piece of it is, in particular, I think about hard cases that maybe uh, I can't give much to a trainee or a fellow to be able to participate in. It's just taking the time to narrate what I'm doing. How am I approaching this? What am I seeing? Why did I choose to do X, Y, or Z in that particular step? And again, I think I started this by saying there's more learning than doing in the operating room and helping people to understand that both are valued and important parts of their learning. That can help, I think, people who are getting started in education, recognizing that they don't just have to hand off the whole procedure to a trainee. There are many ways that they can communicate that approach, the skill, the just the thought process that goes into surgery. It's also about decision making and just not the physical act.
Yeah, that's a great point. Thank you both. So you both essentially are talking about scaffolding. And so what we as surgeons need to do is provide the foundations upon which our learners can build, thereby being able to communicate, recognizing what they are not capable of doing, working on those things, and then being able to garner the nitty-gritty of, you know, how am I going to conduct XYZ surgery? If you don't even know how to function in the operating room, or you don't even know, some medical students come to us and, they don't know how to scrub. That's a problem, right? Or they don't have a concept of, anatomy. I've had some students tell me that the bladder is the omentum. That's a problem, but you shouldn't then expect me to have you sew something, right?
Mhm.
Um, and so, Dr. Newton, you talked a little bit earlier about setting those expectations for the learner, and I think this is a great segue into talking about educational timeouts.
Mhm.
And can you tell me a little bit about what you consider to be an educational timeout and how do you use it in your practice?
Yeah, I think another term have heard used in literature that's very similar to the educational timeout is the approach BID, briefing, interoperative, or intraoperative teaching and debriefing. And so I think of it as that first part, the setting the objectives, setting the expectations, as you may be at the scrub sink and the team is all getting ready to scrub into the case and going down the line and understanding what's each person's stated goal for that case. And again, that's where you can take the opportunity to correct those expectations if needed, so that people walk into the room knowing what they're going to realistically achieve. And then you think about in the operating room, there are those moments that you then try to name and state, okay, hey, you said you wanted to accomplish this today. Let's talk about it now. You're doing it now. So again, kind of labeling things so people recognize the learning that they are getting is learning, it's education, and trying to frame that back to their stated goal. And then I think about the debrief for the trying to understand how things work, how things went, and did people how did they feel like they did in terms of achieving their goal and their expectation. I do that personally, actually, in the operating room when people are closing. I think as we uh, I know you've already done a session on feedback. I think there's those opportunities to give feedback. We sometimes let them slip or we don't do them in a timely fashion. We do them removed and people don't really remember what happened. And I think when people are closing, it's a great time to do feedback. It helps model feedback. I think it also helps normalize feedback and takes a little bit of the pressure off. Obviously, I think if there was some real critical feedback that need to happen, that should happen privately. But most of the times, it's just talking through the case. And I think one of the things I notice trainees do a lot, if you just say, "How did that go?" people are going to jump to the negatives, the things they want to work on. So I try to be really intentional to say, what did you do well? And force people to stop and actually tell me what they did well. Because we are by nature people who want to be better, to critique, we're hard on ourselves, and to try to help people to recognize that you actually did something well today. And let's focus on that first before we jump into the ways that we can improve.
Feel very attacked when you say people focus on the negative because that is just me. But I've had so many conversations with residents that, say like, oh, I didn't do this well, I didn't do that. And then I say, stop. What did you do right? And every single one of those conversations then goes dead silent. And it's as if like they they just go blank and they have no concept of what to say. And so I think it's really behooves us as educators to change that paradigm.
Mhm.
And it also creates a culture of psychological safety that, yeah, I can actually discuss what I need to do better and what I did well. And then I can use those tools to do even greater things in the next case.
Mhm.
Dr. Haag, when you hear about educational timeouts, how has that impacted you as a learner?
I think it's, definitely made me think kind of more critically about my goals in a case, and they're really different from what I would have, you know, identified as goals as a resident. I think um, doing things that are not necessarily procedure based, but like we were talking about before, working on communication or kind of doing more challenging aspects of the case. I think thinking about those critically as a trainee, kind of some of the other things that you might not necessarily think about being part of a procedure. So I've definitely kind of been working on those aspects, and then I think how how to implement educational timeouts as as somebody who's going to be a new attending next year. What works for one person doesn't always work for everybody, and so it has been really good during fellowship to kind of see the different ways that people implement those. I definitely know Dr. Newton's technique and kind of some of the other attendings, and kind of how effective they've been, and so probably will as I start off as a new attending, kind of try to implement some of those things too.
Now, I'm going to be a contrarian for 2 seconds because there might be some folks listening or watching that say, okay, educational timeouts. Now I have to do yet another thing in the operating room. This is an all play. How do you respond to that?
Um, I think that the way that Dr. Newton kind of was talking about, it doesn't have to be something separate where you are sitting, necessarily sitting down, but doing it while you're scrubbing or doing it while you're closing, kind of trying to implement those small things, those little conversations while you're doing things that you would normally be doing otherwise in the operating room, and not we've talked a lot about time being important to manage in the OR, and I think when you're implement those into things that you're already doing, I think that's um it helps.
Dr. Newton?
I agree. I think using the components of the day that are already there and built in, and it doesn't require adding things to the day.
Great, great. So, with every episode of MedEd Matters, I like to leave our viewers and our listeners with a MedEd moment. And that MedEd moment is basically a key nugget, overarching theme to take away from the episode that you can use clinically with your learners. So, Dr. Newton, what is your MedEd moment?
I would say just that it takes intentionality. I think we haven't used that word today, but everything we've talked about takes intention to be an educator, but that it can build into the things we're already doing. You label, you set expectations, and I think people get a lot more out of the day than they realize, and you just help frame that for them.
Awesome. Dr. Haig?
I think, thinking about things particularly as a trainee, kind of coming into every case, again, we've talked a lot about kind of goals and expectations and identifying your specific goals or objectives for the case, having reviewed the patient's history and the relevant anatomy and the things that are going to make that procedure, put that procedure a little bit more into context that shows everybody in the operating room that you're invested in the case, that you're invested in, caring for the patient. And I think your teachers will be more likely to reciprocate that interest.
Awesome. Well, Dr. Newton, Dr. Haig, this conversation was amazing. We're definitely going to continue it offline. But I think this was an excellent way to cap the first season of this podcast. And I hope that our viewers and our listeners have really valued this handful of episodes that we've done to lay the foundation on what it means to be a medical educator within academic medicine. But I think it also applies to education outside of the walls of a university, right? We, as physicians, in positions of having knowledge, have a responsibility to provide that knowledge to the next generation in order to improve healthcare outcomes in this country. And, I had a whole other thing that I was going to mention, but I think Dr. Newton brought up that word of intentionality, which I think is super awesome. I think it's important that we be intentional in what do we want to accomplish with our careers. Medical education is a foundation upon which nothing else, upon which everything else is constructed. Our clinical care, our revenue generation, our research portfolios, everything really depends upon, do I actually know what I'm doing? Can I then take care of patients? And then can I innovate in a space to improve both the education of my learners and patients, as well as their healthcare outcomes? And so I think this has been an awesome conversation. And I think this has been an awesome season of Med Matters.
Yeah.
We're going to take a little bit of a hiatus because we're tired and the new academic year is coming. And I hope the tools that you've garnered from this year's series are going to help you as the new interns and fellows arrive. So thank you all for joining us. Thank you, Dr. Newton, Dr. Haag today. And stay tuned to our next season coming this fall. Bye, everyone.